Thank you, Suzanne. Good morning, folks in California. Thank you for allowing me to be present, even if it is by phone. I keep promising I will be there, but unfortunately, I keep denying that it's not going to be busier and busier. So apologies for not being here, but really do appreciate the opportunity. And certainly we appreciate the opportunity and the partnership that we have with SAMHSA. Having Suzanne Fields there has been terrific and has helped us both in terms of thinking about the behavioral health implications of a number of things that we're doing, but also helps us communicate, message some of what we're trying to do to the states and in particular to local authorities, providers, and consumer and recovery groups in those states. I want to talk about three things that are probably, or we hope are on your mind. The first one is the Medicaid program and specifically the expansion proposed under the Medicaid program for 2014 and the application of the essential health benefits of MAPIA to the expansion population. I'd also like to talk a little bit about an opportunity that some states know about and are taking advantage of around rebalancing their community support systems and their long-term service systems. And then finally, touch a little bit on some of the work we have been doing for a number of years, but it really is coming to fruition as it relates to the characteristics of home and community-based services that we had put out from comment earlier last year. So let me just talk a little bit about the changes that we have to the Medicaid benchmark regulation. You may or may not know that we released a notice of proposed rulemaking in January, and comments are due a week from today. So largely what I'm going to talk about today as it relates to the Medicaid expansion is what we proposed within this document. And while I can say what's in that document, I don't have the tea leaves about where we're going to land because, again, we're in the middle of an NPRM process. The NPRM that we released was kind of a second release around this information. We felt like we needed to give states some guidance about what we were going to do sooner rather than later, and so prior to the regulations that we put out there for comment, we put out a state Medicaid director letter about 3 months ago around Section 1937, which is the benchmark plan section that will apply to the expansion population. Couple other things before I go and talk what's in that regulation. And is that we are no longer calling the Medicaid benchmark plans or benchmark equivalent plans those titles. We're now calling them alternative benefit plans. The reason that we renamed this section is that term benchmark was being used elsewhere in the organization and was causing confusion. So I think while we'll miss our name, we are happy that and hoping that this change provides some clarity. The proposed reg that's out there hopefully provides a better sense of our role in the state Medicaid agency's role with respect to the provision of the essential health benefits. We also, through the regulation that's on the street, had a revised definition of medically frail. And I'll talk a little bit about that because when I read the regulation back in 2010, I found it terribly confusing in terms of what medically frail meant or didn't mean for individuals with mental health and substance use conditions. We also clarified in this regulation, and this is an important clarification, that states may use other benefits that are outside their typical state plan benefits, their 1905A benefits, to be able to supplement their benchmark plans. And those could be services that were either in our 1915I state plan, which is very similar to what states can include in their 1915C Home and Community-Based Services Plan, the 1915J, the 1915K, which is the Community First Choice, which I am happy to say California is the first recipient of a state plan under that authority, and then 1945 of the Act, which is the Health Home Act. And I'll talk a little bit about that supplementation. We also clarified in the regulation that we put out there that individuals in the new adult eligibility group, so that's for those individuals that are 133 to 138% of the federal poverty level, will receive benefits through an alternative benefit plan, whether that plan is offered as part of a managed care organization and arrangement, or whether or not it is offered through some other arrangement, fee-for-service, or perhaps even managed fee-for-services. There are populations that will continue to be exempt for the mandatory enrollment in an alternative benefit plan. The ones that were in the 2010 regulation will continue to be exempt, and by being exempt, those people then have the opportunity to be covered through the regular Medicaid program. So if we go to the next slide that talks a little bit about the alternative benefit plan coverage options, there are some differences in the way that the 2010 regulation was constructed around what choices states have for alternative benefit plans, and the 2012 NPRM around the essential health benefit plans, which make it a little complicated to understand how those two interact. But I'm going to try to walk you through it a little bit, and if there are questions, I'm sure there will, we'll try to talk a little bit more about it. So when states are considering their alternative benefit plan, and I believe California is one of those states, then they have to start where the 1937 regulation listed the options. And those options are on those slides. Hopefully these are not new or this isn't new information, but the four options that states have as a starting point are the standard Blue Cross Blue Shield preferred provider option, and that's offered through the federal employee health plans. The second is the state employee coverage that is available to state employees, so regardless of size of plan. If there are five, a Medicaid agency could choose any one of the five as a starting point. The third option would be the largest HMO in that state, the largest insured commercial HMO in that state. And then the fourth one, which is different than what you see as part of the offerings around the benchmark plans on the marketplace side, is Secretary-approved coverage. And it should be noted that we've had the ability, and states have had the ability, to be able to offer alternative benefit plans. We've got 11 states now with alternative benefit plans, and most of them have choose the Secretary-approved coverage. And most of these states, again, this is historical and perhaps not a prediction of what's going to happen in the future, have taken their Medicaid plan as their Secretary-approved coverage and made some modifications to their plan in order to be able to develop their alternative benefit plan. So what's the steps that states are going to need to take to design a Medicaid alternative benefit plan as we had proposed in the NPRM? So first of all, the state's going to have to take an option that I just talked about, one of those four. And then once they choose one of those four, they have to determine if one of those four are consistent consistent with the four options that were laid out in November as a way that states would have to define their essential health benefits. So there are some slight differences between what was in the 1937 starting point for Medicaid and what was proposed by the Secretary for Essential Health Benefits. And so if, in fact, the state chooses one that to start that is the same as what was proposed in the 2012 Essential Health Benefit benchmark plan, then they will meet the provision for the standards of coverage as long as all HB categories are included in whatever benchmark plan they choose. If not, then the state is going to have to select one of the benchmark plans. So if a state chose the fifth smallest, or if they chose the Secretary-approved plan, they're still going to have to take that Secretary-approved coverage that they're proposing and benchmark it against one of the 10 options that was in the essential health benefit regulations. It's complicated. I understand that, but we are walking states through and willing to walk others through how to be able to do that crosswalk. So the next part that I wanted to talk about are the alternative benefit plans as of January 1st, 2014, which is the next slide. We were really clear in what we put out there in terms of our NPRM is that alternative benefit plans must cover the 10 essential health benefits. That was required both by law, and therefore we put it in regulation. And we're clear that the alternative benefit plans must comply with the requirements of MAPIA. So they have to cover mental health and substance abuse benefits, and they have to cover those consistent with the Mental Health Parity and Addiction Equity Act. And again, what we tried to do in our state Medicaid director letter that we sent out a few weeks ago was to say around the alternative benefit plans that regardless of whether those plans are operating in a managed care environment or a fee-for-service environment or a managed fee-for-service environment or another type of environment, our expectation is that those plans have to meet parity. There are some differences between what was proposed in the essential health benefits in Medicaid and the exchanges, which are now being called the marketplaces. And I think a few of these are worth noting. There are a couple of essential health benefit categories where Medicaid policy is the predominant policy. So, for instance, in the category of rehabilitation and habilitation benefits, especially around the habilitation benefit, we're clear that the state Medicaid agency and not the issuers, meaning the plans, or the exchanges, are going to define the habilitation benefit. Second is that we are being clear in part of our proposed rulemaking that children that are under the age of 21 that are enrolled in an alternative benefit program or plan must receive EPSDT, especially and including pediatric, oral, and vision services. And then the third third EHB category where there is a variation is that we are clear that for the pharmacy benefit, that the regulations that we have in place on the Medicaid side, Section 1927, will apply to the Medicaid alternative benefit plan, which means that the formulary that's available under your Medicaid program currently would be available under the alternative benefit plan. States could not choose to have a pharmacy benefit that was different than their current Medicaid pharmacy program. So those are important differences, and again, we're very interested in getting comments back on what we proposed. I did talk a little bit about the changes that we made to the Frail definition, and so I just want people to pay attention to that as well, because we are asking comments around that, and we have redefined medically frail to be a little bit more specific. It includes children with serious emotional disturbances and adults with serious mental illness. That was the SED kids were included in the 2010 regulation, but it was not clear about adults with serious mental illness. And then we also are asking comments on whether individuals with a substance use disorder should be added to the definition of medically frail. We did not want to assume that they are or that they're not. We gave it some thought and tried to develop a policy decision, but we felt like it made more sense to put that out for public comment and let the public tell us how they felt about the inclusion of the medically frail or substance abuse be included in medically frail, which would exempt them from the benchmark plan. So I'm going to talk about two other things quickly, and then I think we probably have some time for questions, but I'll defer that to our hosts. I do want to talk a little bit about the Balancing Incentive Program, and it is a program that was available and still is under the Affordable Care Act. It allows enhanced federal matching funds to be able to divert individuals from various institutional settings and allow them to receive home and community-based services.
Well, the marvels of technology, right?
Do you want me to call on myself?
We're recalling him. I heard that little fuzz at the end. I have to say, unfortunately, we're going to be out of time for questions. We were early before. Now we're mic. Is that working? I'll just talk loud. Unfortunately, we are out of time. We're running late. Is Secretary Welkening here? Okay. Will be just a minute. And Victor Kogler, wherever you are, why don't you come on up? Is he back on? Okay, John, we just have a couple more minutes. We're running a little late, so if you want to finish up, that would be terrific.
Okay, so anyway, I just, on the next slide, it does have information around the other types of programs that we are interested in getting people interested in. Again, California was the community first choice state, and we're pretty excited about this. Then the last few slides that I have are around the home and community-based services proposed characteristics, and some of this is directly related to some of our work we've been doing over the last several years with a number of our federal partners to be able to address Americans with Disabilities Act violations so that we can ensure that people get services in the most integrated setting, whether those settings are where people live or where they go to work or other places. And so I won't go through each one of the proposed characteristics. I just wanted to let folks know that there are these proposed characteristics that had been out there for public comment. We're in the process now of finalizing those proposed characteristics and want, again, states, providers, consumers to understand that we really are trying to work on policy that are going to move the needle forward around integration, both in terms of what people do during the day and where people live. So, Sandra, let me stop there and let folks know that if they'd like some additional information, we can get that to them.
So if anyone has a burning question, you want to ask Suzanne or John, this is your 1 minute that we're going to have to do that. But you can jump to the microphone. There we go. Tom.
Okay, here we go. Either Suzanne or John, Tom Renfrey with CADPAC. Just a quick question regarding parity. My understanding is that if a state's benefit plan does not meet parity, that the secretary can require the state to go back and supplement the plan to provide mental health or substance use services at parity. My question is, has this happened in any other state yet? Or, and second part of that question is, what's the process for, advocates like us to appeal to the secretary if we believe that our state's plan does not meet parity?
So Suzanne, let me start, and then maybe you can help me out here. So Tom, good to hear your voice. A couple things. One is, I think it's important to bifurcate it into both essential health benefits and parity. So one of the things that we will be looking at, and just to developmentally where states are, especially it relates to the Medicaid expansion proposals. We have not gotten in a Medicaid expansion proposal yet. We've had a number of states talk to us about what they're thinking and helping them think through the parity issues, but we have not formally gotten a application around an alternative benefit plan from states. So it's two things. One is we have a process, CMS has a process on the Medicaid side where states will have to complete an electronic template, which is brand new for CMS, around each one of the essential health benefit categories. We will be able to tell when that state submits the essential health benefit or the template whether or not they have coverage in each one of those 10 essential health benefits. For mental health and substance abuse, we will apply the parity test, which is we will look at whether or not what they're proposing is consistent with the scope of services that is currently in the interim final regulation. We will also make sure that they are, if they exist, applying treatment limits that are consistent with medical surgical practices, and then we will also be asking them specifically about how they are managing that benefit, specifically around any non-quantified treatment limits and utilization management processes, and again, understanding how they're applying that versus how they might be applying that or not on the medical surgical side. So we will work with states before they submit, during their submission, but again, we're being very clear with some states that are coming in with us conceptually where we're finding a problem. We're telling them that that is not consistent with parity and that they have to make those changes before they submit. Around your last question, in terms of conversations either with us or with the Secretary, I think we're very interested. Our regional offices are very interested in the concerns that you're having about the alternative benefit plans in particular. And I'll just say there is a requirement in the new regulation that talks about the public process and public comment period around alternative benefit plans. And I would want people to look at that and use that when your alternative benefit plan is being proposed.
To add, Suzanne?
The additional pieces, the two additional pieces I would add is specific to the role of your state insurance commissioner for enforcement around parity. There is education and training materials and information available for insurance commissioners related to parity in that piece, given their role for enforcement. The second piece I would note is that John and I are starting some joint calls between the SAMHSA regional folks and the CMS regional folks that will be starting with a specific focus on issues around parity because of the information that both CMS regional and SAMHSA regional folks hear from all of you as they're out in the field. So we are working to identify multiple ways that we can understand and hear about issues that are happening.
That's really good news. So we're way late. The two people are standing. You're our last questions, okay? So
hopefully this is a quick question, and I don't know if this is better for you, Suzanne or John, but I believe in John's presentation he talked about how certain populations will remain exempt from alternative benchmark plans. So my question is, if an individual is exempt from a plan and chooses to enroll instead in the traditional plan, what is the FMAP for that individual? Will the enhanced 100% FMAP still apply, or will it go down to the traditional FMAP?
So if this is a newly eligible individual, the 100% FMAP will apply,
Great, thank you.
regardless of whether they choose to remain in the benchmark or they choose to exempt themselves from the benchmark and use the Medicaid plan.
Good news. Last question.
Your mic's not on? We'll repeat your question.
Hello? Okay, there you go. Kristen Jacobson. I had a question about how does the essential benefits and parity get brought to the existing Medi-Cal population, and what's the mechanism to make sure that, you know, there's one mechanism to make sure the expansion population is complying with the essential benefits and the parity, but what's the mechanism for ensuring that the regular Medi-Cal plan is also complying with the essential benefits and the parity? And then if you could also speak a little bit on the parity side, when you have a medical service or a traditionally thought of medical service that is actually being used for a mental health condition, how do the visit limits there apply? Because we have health plans saying, well, that's a medical service, so we can limit it, but it's for a mental health condition, and so it would seem like it shouldn't be able to be limited.
John?
Okay, so a couple things. One is the essential health benefit in the Medicaid world only applies to the alternative benefit plan. It does not apply to the existing Medicaid program. So I want to clarify that. In terms of parity and application to the other Medicaid authorities, that's a terrific question. So as I said, parity does apply to the alternative benefit plans. It also applies to CHIP programs. So we have been very clear about that since 2009, even before the interim final regulation came out. Where it gets challenging is the other parts of Medicaid. Parity does not apply to the Medicaid state plan. We have no statutory or regulatory authority to apply Medicaid or parity to the Medicaid state plan. And then for managed care arrangements that are offered through a couple of our authorities, and I won't bore you with the details, we have the ability to apply certain parts of parity to those managed care arrangements. But unfortunately, some of those managed care arrangements are directly tied to what's included in a state plan. In state plans, they have limits, and some states have limits, and the way that the parity statute and regulation, and there's a number of statutes and regulations that influence the Medicaid program around parity, were written. They're a little bit clumsy, and therefore on kind of more traditional managed care arrangements, we have some ability, but not the complete ability to implement a PIA like we do on the alternative benefit plan.
Hey, thank you. I do want to let you know that these slides will be on our website, cimh.org, and they'll be up probably as early as tomorrow, so you will have those available to you.